opportunity to present. So today we'll be talking on minimally invasive glaucoma surgery, or MIGS. No financial disclosures. So there are a number of different MIGS options that are currently available in the United States and in Europe. I understand that their introduction, as Dr. Mayuri pointed out, is also happening in India with the iStent and the trabectome coming over. So some of the things that we're going to be talking about today are conventional outflow devices that go into Schlemm's canal, as well as bypass devices such as mainly subconjunctival devices. So the advent of the iStent was pretty revolutionary as it kind of was the first device in the minimally invasive glaucoma surgery space. Since the iStent inject has also come out, the Hydrus microstent has also come out. The Zen is a subconjunctival device, and the PreserFlow device is another device that's kind of in the pipeline and will be introduced sometime within the coming year in the United States. So first, let's talk about the Hydrus microstent. This is a flexible, biocompatible 8 mm in length microstent. It's made of nitinol, which is a highly biocompatible material that's used in cardiovascular stents. There's some question of whether or not patients with nickel allergy shouldn't get this device. There haven't really been any cases reported of this quite yet, but it has sparked some discussion. This device is contoured to match the canal curvature, so you can easily see that it's curved and kind of matches Schlemm's canal. It has 3 open windows that face the anterior chamber, which you can see with the red arrows. And the canal-facing surface of this device is completely open for collector channel access. So the entire back side of the device is open to the collector channels. So next we have a video. Not sure if this is going to work, but video here, great. So we can see here the stent going into Schlemm's canal. You can see the 3 windows within Schlemm's canal of the stent. And because it is a rather large device, 8 mm in length, we can have confidence that it is accessing the collector channels, whereas some of the smaller devices like iStent, sometimes we're not quite sure if we've accessed the collector channels. So here you can see on gonioscopy the 3 windows of the Hydrus device. So some of the pivotal studies regarding this device, the first one was the Horizon study. The objective of this study was to compare Hydrus plus cataract extraction versus cataract extraction alone. 556 patients were involved. There was a randomization to Hydrus plus cataract extraction versus cataract extraction alone. There was a medication washout period. The primary endpoint in the study was unmedicated IOP. Secondary endpoint was a medication-free state. And there were no serious adverse events that were found in the study. We'll dive into the data a little bit deeper. So in the primary endpoint, 20% or more IOP reduction. At 24 months, there was quite a bit of a difference that was noted at 19.5% in the Hydrus plus microstent group, Hydrus plus cataract surgery group versus the cataract surgery group alone. And you'll see here that at 1 year, there was a 16% difference that actually grew to a almost 20% difference at 2 years. So the device seems to be equally effective over time, and whereas cataract surgery's IOP lowering effect may be, kind of less effective over time, Hydrus kind of maintains good IOP lowering effect even at the 2-year state. The second endpoint was medication-free state, and we can see at the 2-year time point there was a 30% difference among those who underwent cataract surgery alone versus those who also had the Hydrus microstent. So there was a pretty good treatment effect that we can see with the Hydrus. So the Hydrus microstent is currently only implantable along with cataract surgery in the United States. So insurance will not reimburse you unless you do cataract surgery as well. So the next step in MIGS for these canal-based devices is testing to see whether or not they have any improvement in IOP just as standalone procedures. So this study, the COMPARE study, compared iStent versus Hydrus as standalone surgery without cataract extraction. So at 12 months, the Hydrus demonstrated a greater rate of complete surgical success and reduced medication use as compared to the iStent. And more Hydrus patients were completely off of medication as compared to the iStent. There was secondary glaucoma surgery that was performed on 2 eyes in the eye stent group and none in the Hydrus group. So at least based on this study, it looks like the Hydrus might be more effective than the eye stent if you're not doing cataract surgery. The next device we'll talk about is the Vengel stent. So this is a subconjunctival device that's 6 millimeters in length, has an internal diameter of 45 microns. So you can see it's very small compared to a dime, so that's the smallest coin in US currency, and it's much smaller than that, of course. It's composed of gelatin that's derived from the porcine dermis. It's formed into a cylindrical tube and it's cross-linked with glutaraldehyde. Prior to implantation, the stent is hard, but it is bendable, and once it's implanted, the stent hydrates and swells to create a soft, flexible drainage channel that conforms to tissues. And you can see this in the rightmost photo here. This is an anterior segment OCT picture that shows the stent partially in the AC and going into the subconjunctival state. Clearly here it's bent. The stent comes preloaded into a 27 gauge injector, which you see here on the left. Implantation of this device can be either ab interno or ab externo. It can be transconjunctival or with open conjunctiva. It creates a track through the cornea along for flow of aqueous humor from the anterior chamber into the subconjunctival space, which you see here in this first photo labeled A. It can be done as a standalone procedure. So in terms of effectiveness, in this large study out of Texas, Dr. Grover's group found that 76% of patients achieved an IOP reduction of more than 20% at 12 months on the same or fewer medications. So you can see this group had a mean medication of 3.5. So they were on 3 to 4 meds each, and over the 12-month time period, they did achieve some pressure lowering. However, a third of them required needling and 9 of them required a second glaucoma procedure. So this surgery is not perfect. Next, we'll touch on PreserFlow. This is a device that's currently not approved in the US, but should be in the next few months, or should be introduced in the next few months. It's designed for ab external implantation under Tenon's capsule. It's a little bit longer. It's 8.5 millimeters in length. It has a 70 micron lumen, has a wing design to direct the orientation of the device. That doesn't have a plate, so potentially it's less traumatic than a tube shunt surgery. And it's made of a biocompatible material that's a mix between silicone, rubber, and polyurethane. So the large randomized clinical trial of this device is still in the works. We don't have the data for that. We can look quickly at the data for mitomycin C, different doses of mitomycin C with the PreserFlow shunt. And what we see here is that they did, sorry, I can keep going. So they looked at mitomycin C of 0.2 milligrams per ml versus 0.4 milligrams per ml, and it did show pretty effective pressure lowering at either mitomycin C dose. The higher dose of mitomycin C did lead to more IOP lowering, not surprisingly. And in terms of adverse events associated with this, so it's things that you think of with trabeculectomy, so increased IOP, numerical hypotony, keratitis, hyphema, etc. So just to close, the release of the eye stent was a groundbreaking change in glaucoma options that are available. We now have many other MIGS devices available. However, we don't really have great long-term studies on any of these devices. So while these may be very exciting and may offer, they may have a niche for various types of glaucoma patients, there still remains to be known whether or not they can provide the long-term benefit that trabeculectomy and tube shunt surgery might be able to do.
Thanks, Dr. Aakriti. Before Dr. Ayala comments on this, is Dr. Nadisha Singh here? Not here. Ma'am, you leaving?